では、時間になりましたので、セミナー、ウェビナーを始めさせていただきます。本日は、世界のソーシャルイノベーション、社会課題、社会問題に対する革新的な解決法にご参加いただき、どうもありがとうございます。私は名古屋大学が主管する起業家育成プロジェクト、とんがりプロジェクトを担当している小西と申します。とんがりプロジェクトでは現在、オンラインツールを活用した海外研修、とんがり丸ごと海外研修を実施しています。そのプログラムの一つであるソーシャルイノベーションセミナーをぜひ多くの方に聞いていただきたいと思いまして公開しました。おかげさまで80名を超える方にご参加いただいております。お申し込みいただいております。はい。午前の部はですね、テキサス大学エルパソ校のコミュニケーション学部の教授であるアービント・シンハル先生をお招きして、アメリカ、インド、ノルウェー、タンザニアにおける社会企業の事例を紹介していただきます。その後、資源の乏しい環境における問題解決に適した手法、ポジティブ・ディビアンス・アプローチを説明していただきます。はい、本日のスケジュールですけれども、今から新春先生にお話しいただきまして、いつもよりちょっと Q&A の時間を長く取りまして、11時半ぐらいから皆様の質問に回答していただく時間を設けます。聞いてみたいことがある方は、チャットに入れていただいている方もいますけれども、チャット機能や Q&A 機能で、どちらでもご都合のいい方で、やりやすい方で入力してください。英語でやっていただくと、私がとても助かりますので、英語にしていただければなと思います。はい、以上が事務説明でした。Okay, I'd like to welcome our speaker, Dr. Arvind Sinhal. Sinhal さん、アービンドさん。
おはようございます。
おはようございます。So, I've just introduced you as my friend and mentor and sometimes master. Okay. so, let's move on your lecture now.
Okay, well, Ohayo gozaimasu. It's a pleasure to join you all the way from El Paso, Texas. It's Sunday evening here. I think it's Monday morning. Your week has begun. I greet each one of you personally. And today we will talk about social innovation in the context of solving complex problems. And maybe while we have this conversation, we will also hear a little bit about what we know as the positive deviance approach. So I'm going to try to share my screen. And okay, is my screen coming through?
Not your slide. It's a YouTube video. Oh, okay.
Okay, no worries.
Okay.
Is my screen coming through now?
Yes.
Terrific. So I like to tell stories. Some of you who are here joining us, my friends from PD Japan and other universities, you know that I like to make sense of life through stories. So we will talk about social innovation with respect to solving complex problems by looking at 4 stories or 4 cases. And if you look at the images, and I'd like you to spend a little bit of time looking at these 4 images. The first image is from the United States, and I'll talk about humanity in a healthcare setting. You can call it social innovation because these days in US hospitals, patient satisfaction is a very important component of how hospitals are reimbursed. So if a hospital doesn't provide a good service, and if they don't provide good service uniformly, then their reimbursement procedures are affected by it. If hospitals provide very good service, and good service in terms of healing not just the patient, but healing in some ways the family in a more holistic way, then the patient satisfaction scores are high, and hospitals in a very competitive environment want to get high scores. The second case that we will talk about is also in healthcare, but in a very different setting. It is an organization by the name of Karma Healthcare, which provides to those patients in rural India who have no access to quality healthcare by using a mobile platform. It creates the conditions for the poorest of the poor people in India to get high quality healthcare along with pharmacy services, along with specialized care, and at a very reasonable cost. And I think the most important thing about this India case is that 80% of their clinics now are turning a profit. So we are looking at social innovation, solving complex problems, but also at the same time making it work in an economically profitable way. The third case is from Norway, and I think you can see some people playing volleyball, and they are dressed differently. This is about humanity in a prison in Norway, and why when guards, so the woman who's got the ball is a guard. 40% of the prison guards in Norway are women, and she's playing with several prisoners. And you can imagine what happens, and this is a maximum security prison. So I'll tell you this story and why this is useful to know. And then lastly, if we have time, if not, I'll send you Konishi Sensei the video clips, and you can see them on your own. But this is a very interesting project on how citizens are engaged, again through mobile telephony and through survey sampling, so that policymakers in Tanzania can respond to their needs in pretty much real time. So anyway, so that's a summary of what is to follow. And Yukiko-san, I just want to do a quick check. Is my voice coming through?
Yeah, perfect.
And am I looking good?
Yes, perfect.
Excellent. And as I forward my slide, can you see my forwarded slide?
Yes, exactly.
Okay, terrific. So this is a very personal story for me. And it is a story where you can look at it from the lens of human-centered social innovation. You can also look at it from the perspective of maybe the role of technology and human processes and how they come together to create social innovation. And this is in the context, as I said, of a US hospital. And profits of hospitals are tied quite closely, as in the case of any kind of customer service, with how satisfied the patients are. And as I've said, this is data is formally collected. The picture that you see is of a preemie baby, a baby that was born several months before the gestational period of 9 months. And it is a deeply personal story because I have two boys, and my second son, who is now 25 years old. So he's 25 now, but when he was born at 6 months. And so if you can imagine a child who weighed 648 grams, which is about 1.5 pounds, 2/3 of a kilo. He had all kinds of issues. He was small for his gestational age. He had an APGAR score. If some of you know what that is, it's an indication of a child's health when they are born. Typically, most children who are born have an APGAR score of 9 or 10. The maximum is 10. My son had an APGAR score of 1. And he stayed in the hospital for about 2 years and went through numerous surgeries and was able to resolve pretty much all of his issues of prematurity, because when you're a premature child, your lungs are not developed. So he had several, years of issues with respect to breathing. He was on oxygen for the first 2 years of his life. He could not keep his food down, so he was fed through a tube that went through his nose and emptied into his jejunum, not even his stomach, because he was liable to regurgitate, and the doctors couldn't take that risk. And you can imagine when a child in a family is not doing well, then the entire family in some ways is affected. We say if somebody is in recovery, the whole family is in recovery. And I think by the time he was 7, most of the issues that he was working with were resolved. So it was a pretty long journey. Now, I want to talk to you about 2 experiences while he was in the hospital as a preemie baby. And you may identify with this. I do not know how doctors do rounds. Rounds meaning when once a day they come to visit their patients in Japan. I don't know how that's done, or how in Japan they do rounds for pediatric or neonatal intensive children, preemie babies. But in the US, typically doctors do rounds once a day. And so imagine, our little baby lying in an incubator, and the doctors, several of them, and it was a teaching hospital, so there were doctors and fellows and residents and interns. There were nurses of all kinds, the feeding nurse, the GI nurse. You had the occupational therapist, because everybody, it's a sort of an intervention to not just keep the child alive, but also to make sure that they develop and thrive. And the way the rounds are done is the doctors come, and typically there may be 30 or 40 little incubators in an intensive care unit for neonatal children. And they come and they stand and they crowd around the incubator. There were as many as 8 or 10 people, because these little babies have lots of issues going on, who come. And here's an image. Yukiko-san, did my second image come through?
Yes.
Terrific. So this is typically what a team looks like, and they're all wonderful people. They are trained very well. They really love the child. But most of the time, almost all the time, when they come, not like this picture, they are posing here, but they usually create a circle around the child. And on average, the doctors spend 2 to 3 minutes with every patient. There are 30 or 40 little incubators with little sick children, very sick children. And, the doctors may spend 3 minutes and, in an hour and a half or 2 hours, the rounds are done. And typically what happens as they stand, you can imagine, and they discuss the child's case and their progress and the concerns they have, the parents are, you can imagine, they are behind. And for the parents, this is a somewhat stressful time, as you can imagine, because the doctors come only once a day, and you are very curious to hear what they are saying. And typically, the doctors come, they consult very quickly. Are there any concerns? They make some decisions, maybe increase the oxygen by this, give more medication, try this, or this test needs to be done. They do all these decisions, and then, they move to the next incubator because they've got to go through this very quickly. So the question that you have to ask is, where are the parents, the caregivers? And they really are in the background. So in this particular hospital, it was a teaching hospital. There were 12 neonatologists, meaning 12 very specialized doctors for neonatal children, preemie babies. And all of them, as I said, were excellent doctors. And of course, our child made it. He's 25 now. And, the nurses were very caring. But there was one doctor who represented a case of humanity in a way that I want to share with you. So you can imagine 11 times out of 12, depending on which doctor was the lead doctor that day, what I described as the process, the team coming, crowding around, doing consultation and leaving. The parents are behind. But when this doctor came, he had his team, and it was Dr. Kata, carry something which looked like an umbrella. And from a distance, the first time we saw it. And then as they came, the first thing they did is they opened, and it wasn't an umbrella, it was a stool, like a folding stool. And when they unfolded the stool, they sat around, not stood, not standing, sitting around the incubator on their stools. And you can imagine what that does. When doctors and caregivers sit down, it seems that time slows down. And that's not just with doctors. If you are a teacher and somebody comes to meet you and they knock at your door, and if you open the door and you keep standing up, it does convey the notion that, oh, I'm in a hurry, but if somebody sits down, time seems to slow down. And you can imagine in a healthcare setting, when your child is very sick, this is important to you, that you at least feel that the doctors are not in a hurry. So that's the first step. They sit down, they bring a stool. Most people don't, they sit down. Most doctors who do rounds don't sit down. And then the doctor would say, Dr. Carter would point to us, the parents, and he'd say, Mr. and Mrs. Singhal, would you please pull up your chairs, take some chairs, and come join the circle? And then you say, me? You want me to join the circle? And they say, yes, please, would you join the circle? And so, you join the circle. You feel that you are included. And as I said, in normative cases, the doctors talk amongst themselves and they move to the other patient. not paying much attention to the parents. Maybe they'll wave, maybe they'll nod. And the parents usually have questions, but you can't ask them because, they're busy people and, they're in a group and maybe they don't look at you. How do you ask them a question? But when we were brought into the circle, Dr. Carter would begin by saying, Mr. and Mrs. Singhal, you have been observing your child for the last 24 hours because, we spent a lot of time at the neonatal intensive care unit. And we would like to begin by knowing how you believe your child is doing. And then you say, me? You want to hear from me how my child is doing? And because the doctor invited us to share our concerns, there were at least 3 or 4 times we were able to provide critical input, critical information, which resulted in better clinical outcomes for our son. For instance, when the GI doctor, the gastrointestinal doctor, did a test, they found that our child was not regurgitating. The test showed that everything is good. But once when the child was fed through a tube that emptied into his stomach, we saw that our son vomited. And so we knew that he was not able to keep things down. So our input, even though the medical tests were saying something, was very important for his care. So anyway, the reason why I'm telling you this story is because you can imagine when it comes to patient satisfaction scores, Dr. Carter is exceptional. All other doctors are exceptional doctors, but Dr. Carter, I think, is an exceptional healer. Just the idea of sitting down, slowing down, the idea of inclusion. We want to hear from you, the parents, and what happened because of that yielding. Now, the interesting thing is that Dr. Carter didn't spend any more time than other doctors who spent, on average 3 minutes. So people came, they quickly sat down. First question was, Mr. and Mrs. Singhal, well, would you please join? Then the next very quickly was, what concerns do you have? How do you think your child is doing? They heard us maybe for a minute, and then they did their consultation, and then they moved on. So no extra resources, didn't cost anything more, created the enabling condition for the patient to have better clinical outcomes and for the caregivers outside the medical realm, parents or others, to feel that they were included in the child's care. So this is something which is important because it's a sort of a service innovation with human factors. There are some technologies involved, very low technology like a stool or a chair, please join us. But the decisions that are taken are of a significantly higher value. So low tech, but very high touch. Now, a second story from this hospital, just so as to give you a sense that this wasn't an isolated case, although this was still very rare, was when our son went in for surgeries. And our son had multiple surgeries. And when a child goes into a surgery, pre-operation, pre-surgery, the anesthesiologist team comes. And typically when the anesthesiology team comes, they say hello to the parents, and then they say, okay, we'll have to put a certain tube, a certain port, and through which we will administer anesthesia. And so I'm sorry, we'll have to hold your child down, find the spot, the vein where the needle needs to go in. And you can imagine, even though your child may be 684 grams, they really fight it. You know, so as the anesthesiology team very gently tries to hold them down, they squirm. And often it would take 3 or 4 pricks because they are squirming and because they have such little veins before the needle went into the right spot. So basically you can imagine the child is being punctured and it's not a very big child. And if you're a parent, they are screaming their gut off. And because they are screaming, even though they may not have too much lung capacity, it just, you know, it's very traumatic, as you can imagine. Traumatic for you as a parent, for other parents who may be around, whose kids may be coming for pre-op. And of course, it's not fun for the anesthesiology team. So this was regular normative practice. And again, they are all wonderful anesthesiologists, nothing wrong with that. And I want to tell you about Dr. Susan. Much like there were a dozen neonatologists, maybe there were, you know, 8 or 9 anesthesiologists in this teaching hospital. When Dr. Susan came, much like Dr. Carter, she was a little different. How was she different in terms of her behaviors? When she came, she greeted us, the parents. Hello, how are you, Mr. and Mrs. Singhal? I'm Susan, I'm the lead anesthesiologist. This is my team. And then she said, Mr. and Mrs. Singhal, do you give us permission? Do you give me permission so I can pick up your baby and hold your baby? And you say, oh, yes, yes, yes. And very gently, of course, the child has so many tubes here and there, you know, oxygen tube, feeding tube, this tube. She picks up the child, and you can imagine the difference between picking up a child gently with love in contrast to holding the child down so that you could poke a needle. And the child senses it, no? So you can imagine when the child is picked up, it's calm. And what Dr. Susan did for the first minute was she administered to our son, Anshuman, what we call verbal anesthesia. And what is verbal anesthesia? Verbal anesthesia is use your words to calm and distract the child. In her case, she used something that we do here in the US called peekaboo. So she'd say peekaboo to the child, and then she would move her head, and you know, our son would be distracted. And while he was distracted, she would gently massage his upper thigh, and one of her assistants, because the child is calm and distracted, would take a needle and put the needle in first time bingo. The needle goes in at the right place, it is secured in place. By the time that child realizes that something has happened, the port is secured, and now, of course, Dr. Susan can calm the child. So again, much like Dr. Carter and what he did, what Dr. Susan did was very different. And what was the different? Coming and introducing herself, asking for permission, may I lift your child, administering verbal anesthesia, massaging the child's thigh, having an assistant find the right spot, secure. So far better clinical outcomes for the child, as opposed to being, you know, poked 4 or 5 times just once. And we know that any poking is a risk for infection transfer. And you can imagine what the relational outcomes were. No screaming, no, you know, trauma of any kind. Well, it didn't stop here. After the child was secured, the port was secured, Dr. Susan said, Mr. and Mrs. Singhal, would you please give me permission to carry your child to the operation theater? And you say, carry my child? She said, yes, if you give me permission, I'd like to carry your child. And you know what the normative process is? The normative process is every child is wheeled in, right, in their little bed, their incubator. In our case, the anesthesiologist was asking us for permission for the child to be carried. And she took a few steps. Of course, we gave her permission towards the operation theater. And then she turned back. She looked at us, the parents, and just sort of nodded, patted the child and nodded, as if she was telling us, don't worry, your son will be okay with me. And you can imagine what that does for parents. When the doctor who is walking your child to the operation theater, who's going to put your child to sleep, and hopefully, bring him back awake, is telling you, don't worry, he'd be okay with me. Now, I again tell you these two cases because they are low tech. Carrying a child is as low tech as it can get, but very high touch. And all of these things cumulatively are related to patient satisfaction scores, the reputation of the hospital, the reputation of the doctors, and of course that translates into more patients and profits. So this is my son, and that's me. I had a head full of hair at that time. I wore more colorful clothes at that time than I do now. I think this is after one of his major surgeries. So he's about 2.5 years old. And I think he's very happy because he's got my glasses in his hand. And my son just turned 25. So that's his picture on his 25th birthday with his brother. It's in that sense sort of a happy story. So Yukiko-san, so far so good. Are you able to hear me? Are these pictures coming through?
Yes, it's great.
Okay, good. So I think this might be a time to introduce this concept of positive deviance. And what I'd like you to do is to focus on the image. And, so while you have some people who decide that they are going to carry a wheel, and of course, then they're tired and it's pretty uphill. But, when you carry a wheel, you, with some effort, can take it to a height, to an elevation. Whereas you have one person who has figured out that you could simply roll the wheel. So when we talk about the word positive deviance, what we are saying is among the dozen neonatologists in this hospital in Columbus, Ohio, where our son was, there was one, Dr. Carter, who had figured out a way by having his patients be well looked after, requesting his staff to carry stools, encouraging the parents to come and join the circle, asking parents for their inputs. And similarly, Dr. Susan, who had figured out a way to create the conditions to not wheel the child, but to carry the child. So positive deviance is the simple notion that in every community, whether it's of doctors or neonatologists or anesthesiologists, there are some people who at no extra cost have figured out a way to create extraordinary outcomes, whether in patient satisfaction or family care as healers than most others. And we are not degrading the others. We are just saying that we can learn a lot about human-centered social innovation or low-tech centered social innovation directly tied to the profit line by these positive deviants. Okay, so we are going to case 2. That was case 1 in the US. And case 2 is quality healthcare for the underserved in India. Now, this organization, Karma Healthcare, which provides these services in India, was started about 6 years ago. I have been an advisor to this organization from the time that it began. The organization was started by my friend Jagdeep, whom you see in a turban and in a blue shirt. And what Jagdeep is doing, as you can see, is he is helping a nurse take the blood pressure of a patient. From looking at the patient, you can tell he's a rural patient. And that is the mission of Karma, that is to provide quality healthcare through qualified medical doctors to patients in rural areas. And there are 800 million people who live in rural parts of India, almost 2/3 of India's population. We have a population of 1.25 billion. So 800 million who live in rural or semi-urban areas where there is a tremendous paucity, shortage of doctors. Most of the doctors are concentrated, as you can imagine, in cities. And in the aggregate, India only has 1/6 of its doctors. So if the need in India was 6 million doctors, India only has 1 million, and they are mostly located in urban areas. So what Jagdeep has done, now a little story, he's got an MBA degree. He's 35 years old now. He was a technology analyst for Goldman Sachs in New York. So, you know, he could have lived a very good life. But then he returned back to India, worked in tuberculosis control in rural India, and then basically said that I'm going to dedicate my life to fulfill a social need, but I will do it in a way that I can scale it and make it profitable. So he started 6 years ago with one clinic, and now he has 30 clinics. This morning I spoke to him, and he told me that Hyundai, the Korean car corporation, has just funded 20 more clinics for him. They are so excited about this that as part of their corporate citizenship program, they have funded 20 more clinics in rural areas. That's the nonprofit part of Karma Healthcare. The profit part, you know, is based on generating revenues as opposed to just fulfilling a need. So what happens is in a rural area, a patient comes, and these are nurse-assisted e-clinics. So you can't have doctors in a rural area, but you can have nurses. So they find a nurse from the local area who's trained, and that's the woman sitting in the white coat. And this clinic is run by her. So it has a physical space. The patient comes in, the nurse in their own language greets the patient, and the nurse then takes their blood pressure, their oxygen saturation, their pulse rate, their heart rate, etc., etc. And then all this information is communicated to a doctor that's sitting in the city. So on the screen, you can see the screen that, and you know, the patient is, the doctor is saying, I want to see your tongue, no? So the patient is showing her tongue to the doctor who's on the screen. And so the nurse communicates the vitals, blood pressure, pulse rate, heart rate, you know, oxygen saturation, temperature to the doctor electronically. And they have these simple web platforms. The doctor then has a one-on-one, face-to-face, mediated by a screen consultation with the patient. He writes out a prescription electronically, which the nurse can then print. And believe it or not, these clinics have a pharmacy attached to it. the pharmacy has, and that's your pharmacy, they have 200 of the most basic medications that a doctor prescribes, you know, for diabetes or for blood pressure or for whatever. And it also has about a dozen tests, diagnostics. So it has a pharmacy, it has diagnostics, so, you know, a pregnancy test or a malaria test or some kind of a blood test to check for this or check for that. You know, what's the iron content, what's the hemoglobin, you know, a sugar dip just to check your sugar, etc. And Karma, so in one stop, it provides all services, no? Primary care, prescription, pharmacy, diagnostics, and it has a referral service. So if the doctor feels that, you know, somebody needs to be seen, then they make a particular referral to another doctor who can see the patient, and of course the costs are controlled that way, and the patient is not left out to figure things out on their own. The remarkable thing, and this will blow your mind, in the last 6 years, the average cost that a patient pays for doctor consultation and their medication together is close to $4, $4 US. And that's remarkable that this comprehensive service can be provided. And given they have multiple clinics and their footfall has been increasing because, you know, as patients get better, they recommend, it's taken some time, but these clinics have begun to become profitable because they have a lot of repeat customers. A customer who's had a good experience, you know, now recommends it to other customers. And as I said, just this morning, Jagdeep told me that Hundi Motor Corporation has funded 20 more clinics. So Yukiko-san, I'm going to try to see if I can play this video.
Okay.
And it is the story of Karma Healthcare. And it's a short 4 or 5 minute video. When the video is playing, if you could just tell me if you can see it. Yeah?
Okay.
You can?
Yes, but
800 million people
you can.
in semi-urban and rural India. Majority of this population is young and middle-aged. With growing income levels, these people are
Abindo-san, the sound does not come.
Yukiko-san,
Yes.
is the sound okay?
No, I cannot hear the sound.
Okay.
Could you try again?
I will try again. Let me see. Could somebody else tell us if they can hear it? Somebody, some other people? Let me just wear my glasses.
behind in comparison with other developing nations. In the absence of these doctors,
can you hear it? You can hear it now?
Yes.
Okay, I'll play it again. Okay, so maybe I'll just rewind it.
these people are increasingly seeking better quality healthcare for themselves and their families. India has 1/6 the number of doctors it needs and lags far behind in comparison with other developing nations. In the absence of these doctors, most people seek healthcare services from unqualified providers or quacks. The result is a combination of highly inaccurate diagnosis and ineffective treatment, typically with a mocktail of steroids and antibiotics. In most cases, patients pay greater than 300 rupees per visit. Karma Healthcare is a digitally enabled enterprise that provides affordable, accessible, and quality healthcare in semi-urban and rural India. It uses a judicious mix of technology and on-ground interventions to deliver a high-quality consumer experience. In the journey so far, we have established 10 nurse-assisted e-doctor clinics. Each clinic provides services like primary care, selected secondary care, diagnostics, and referral support. The model partners with doctors and hospitals in nearby urban cities, thus leveraging existing capacities. Each clinic follows a standard operating procedure. A patient entering the clinic is met by a certified and trained nurse. After e-doctor's welcome message is played, the nurse converses with the patient in the local dialect to record patient information and clinical history using POC medical devices. The nurse then facilitates a face-to-face video consultation with the doctor. The doctor consults the patient and creates a digitally signed prescription on the technology platform.
हमारे यहाँ पर लगभग सभी तरह की बीमारियों का इलाज होता है, जिसमें अधिकतर डायबिटीज, मलेरिया, हाइपरटेंशन और अस्थमा, गायनिक के पेशेंट आते हैं. इसमें बड़े भी आते हैं, बच्चे भी आते हैं और लेडीज भी रहती है.
Affordable medicines are provided to patients through a partner pharmacy co-located with the clinic.
ये हॉस्पिटल हमारे गांव में है, इसलिए हमको गांव से बाहर नहीं जाना पड़ता है और उदयपुर जाते हैं, हम बाहर जाते हैं तो अनजान होते हैं, इधर उधर भटकते हैं और एक जना हमारे साथ लेके जाते हैं तो हमारे पैसा भी ज्यादा होता है और यहाँ पे हमारा संतुष्ट से, आराम से, शांति से और सब इलाज हो जाता है.
To enhance customer experience, patients are handed out a digital health card. Karma plans to link the patient records to Aadhaar to expand its linkages with insurance and pharmaceutical firms. As technology evolves, Karma looks to widen its gamut of patient care services. Some examples are treatment of non-communicable diseases, oncology services, renal care, eye care services, and so on. In the absence of e-doctor clinics, patients would have had to travel many kilometers and incur additional costs to seek healthcare services. The linchpin of the entire operating model is Karma's in-house technology platform, which incorporates features such as automated doctor selection and triaging of critical cases. The platform uses a mix of rule-based and semi-AI features to reduce chances of human error and improve quality. Some examples of this are prescription validation systems, automated voice alerts for transparent pricing, and alerts for diagnostic or treatment mismatches. Karma's clinical decision support system ensures standardized treatment and can thus be seamlessly scaled to various clinical settings across geographies. Karma's overarching vision is to establish a pan-India network of healthcare centers. In this increasingly digital world, we believe Karma can transform the industry to make healthcare more inclusive, integrated, and accessible.
Okay. Yukiko-san, did that play okay?
Yes. Thank you for sharing the video. We learned a lot from that.
Excellent, excellent. So this video, as you can tell, was a little old. Now Karma has about 30 clinics. They serve about 400 villages in India. They have close to 1 million doctor-patient encounters, number of lives touched. And they have added specialty services. So if a patient in rural India wants to consult an OBGYN doctor for pregnancy, a pediatrician for their child's health, a skin doctor for their skin ailments. These special services are provided. It employs about 125 people now. And as I said, their idea is to go to about 250 to 300 clinics in the next phase of funding, because they have shown proof of concept. And then, of course, the need in India is tremendous. So that's an example of, again, using mobile platforms. The important thing with Karma is the human interface of the nurse. There are so many digital platforms which think you can just connect a patient with a doctor. In the context of rural India, having the nurse who speaks the local language, who keeps the clinic clean, who in a very polite way takes all your vitals, gives you a health card, everything is automated. And of course, as you could tell, Karma is using AI, artificial intelligence, just to make sure that there's medication reconciliation, to triage patients who need critical care, alerts, pricing. It's not that the clinic charges something and the nurse can charge something else. They do not just a printed receipt, but a voice receipt that, this is how much. And they have basically developed all these features, and over a 6-year period, their platform has gotten better and better. And, now they are beginning to use predictive analytics. They are presently working in 2 states of India, but in these 2 states, for instance, if there are more cases of COVID-19 or more cases of malaria or more cases of tuberculosis, Karma knows about that instantly. And they can then dovetail with the local health system to provide this information to local health authorities, so that they can take care of little epidemics and so on and so forth. So anyway, so that's Karma. And again, as you think of Karma, think of it in the context of a positively deviant institution that provides high quality care to the poorest of the poor in rural areas where there are no doctors, at a cost that is very low, with a pharmacy and diagnostics right there, and referral service and follow-up, and also to make money. And that's the vision. It's taken them 6 years. They still have a long way to go, but you can perhaps see how user-centered or how human-centered social innovation, but in a profit setting. Karma also has a non-profit arm called Anhad India, and that's the non-profit arm which was funded. First, Hyundai funded 2 clinics, and now they've gone to 20 clinics. So in areas where there is tremendous need outside the realm of its for-profit operations, there is the operation of the non-profit Anhad clinics. Okay, Yukiko-san?
Yes.
How am I doing so far? Am I doing okay?
Yeah, okay, but there is some questions about the India case. So could you?
Okay. Would you like me to take the questions as they come in, or would you like me to take the questions at the end? I'm okay to do.
So, okay, so let's open question time.
Okay.
And my student Shivan, just a moment. Could you speak up and ask a question directly? So Shivan is from India.
All right.
Okay.
No,
Go
actually,
ahead.
no, sir.
Go ahead, Shivam.
The thing is that I have lived in rural India, and there's more stereotypical stigma about not going to doctors in rural India. I mean, even even if you create the clinics, there's more of the need of education there. How is it? How is it? How is karma dealing with it? Right? If it's like, I mean, it's like a clinic system, but if the people don't go in there, there's no like no profit out of it. Sorry. Yeah.
So Shivam, what I'm saying is that they have 30 clinics. Obviously, they have served 1 million people. So million is a good number in the last 6 years. So people are going. 85% of those who come are repeat customers, which gives us a sense that they have a good experience. And yes, there are lots of problems in rural areas, and you've lived there, so you know. Karma is not in the business of education as in primary education. They are in the business of providing primary healthcare, where typically, since you've lived in rural India, you know, there are mostly quacks that operate as doctors, and they charge a huge sum of money to patients. They have ties with other doctors in cities, so they may make referrals and, you know, they pocket a big commission out of this. So karma's whole purpose in this very difficult scenario that you've just described is through experimentation, through technology analysis, through venture capital, create the conditions for, I think I'm hearing an echo. Shivam, it could be because maybe because your microphone. Thank you for going on mute. So your concerns are valid. All I'm saying is it's growing, it's turning profitable, and venture capitalists want to fund the second round. And you know, they have a very good sense of what is working and what is not. That's not to say that karma has not had issues, but they've been able to work out most of these issues. And the costs of delivering are coming down because the costs of information technology access are coming down. With India now 4G and getting into 5G, the cost of communicating and high quality audio video is going to keep coming down. And if you have clinics and you have pharmacies, you can get drugs at very, very low costs. It's a question of scale. And it also means that you can pass on the economies of scale to each individual patient. So, okay, Yukiko-san, should we take more or should we move on?
Oh, one more question from Kawamura Sensei. Kawamura Sensei, so could you speak up?
Okay, thank you, Alvin, for wonderful lecture. And I have a question about the karma. I wonder if they take like a franchise style, like for example, like collaborating with existing organization in the local area, or just hire directly from the local individuals.
Yeah. So karma is not franchised, Yoko-san or Kawamura Sensei, as let's say a McDonald's is or a Pizza Hut is. And that is also because, they are very early in terms of proof of concept. They do have local partners, so they may work with certainly the local health authorities, the local infrastructure of, pharmacy sales, or even some NGOs, but they do. Thus far, they have done everything on their own. Okay. So it's important for them to hire local nurses. You can imagine why that's important in the context of India. Issues of trust, language, culture, They pay a lot of attention to cleanliness and, you know, providing a very good service environment. And for them, these things are non-negotiable. As Shivam was saying, you know, he's lived in rural India, he knows how things are. Karma is a positive deviant in many ways. And I, of course, encourage Shivam to go and visit a karma clinic, as I would like, you know, others to learn from this example. Yeah.
Thank you.
Okay, so my boss is Kunishi Sensei. Kunishi Sensei, if you tell me we can proceed, I'll proceed.
Yes, you can move on to next topic. Thank you.
Okay, pleasure. So let's see. Do you see the screen? Case number 3, humanity in a Norwegian prison.
Yes.
Terrific. And now maybe you can see the picture of a guard playing volleyball with prisoners, no? And this is not, you know, much like karma may sound like, oh, it's really magical, but it has 30 clinics. In Norway, this is not an anomaly. It is quite normal. The Norwegian prison system is considered to be the most humane prison system in the world. And what do we mean by humane? Well, first one has to go back to the purpose. What's the purpose of a prison system? The purpose of a prison system is to create the conditions for somebody to pay a price for what they may have done. And in this case, this image is from a maximum security prison. So the price that they pay is they don't have the independence to go out of the boundaries of this prison system. That's the price that they pay, that they've lost their independence, their freedom. But within the prison, they are not treated like animals put behind bars, as is the case in many other countries, including here, the United States. Prisoners are put behind bars in cages. And in the US and in many other countries, the prison systems have the view that prisoners, given they've offended, need to be fixed. Yeah, and you fix them by punishing them, you fix them by, you know, having guns, you fix them by having sticks, you fix them by locking them up. In this particular Norwegian prison, and this was built in 2010, it's called Halden. I'd strongly encourage you, if you're ever in Norway, to go visit it or look it up. It's been quite well documented. They have taken a very humane approach to what is called the reintegration of prisoners in society. So the United States has a recidivism rate, just taking an example. Recidivism means how many people who come to a prison and when they are released, how many of them come back again, right? So in the US, 75% of the prisoners who are released within a 5-year period are back for another offense, okay? So by any measure, the prison system is not doing a good job of reinstating people or rehabilitating people. You think that's their role. In Norway, Norway has the lowest recidivism rate in the world, and that number is 18% in maximum security prisons. And this is unbelievable, you know, that they are able to reinstate and reintegrate their prisoners in the mainstream of society. And how do they do it? Well, at Halden, for instance, none of the guards carry any weapons. They're saying, what? No weapons in a maximum security prison? Well, up until 1999, Norway used to have the notion of static security. And what is static security? Basically keep prisoners in their place, no? Punish them, be harsh on them, treat them not as human beings, but as criminals. And then, of course, they've moved to dynamic security, and dynamic security is based on the simple principle of positive interactions between the guards and the prisoners, creating a climate of mutual respect, which leads to safety, which leads to prisoners self-policing themselves. So here you see a guard playing volleyball with them. It would not be unusual for you to see guards playing soccer, going out for a walk with the prisoners, tending to the garden with the prisoners. And the prisoners, when they are in the prison, they pick up all kinds of skills that are marketable, so that when they come out, they are fully reintegrated. So for instance, they have auto repair shops where you can learn about auto repairing. You know, you can become a plumber or a carpenter, or you can pursue your education, become an accountant. And the most interesting finding, even though it costs a lot of money to keep, to have this kind of a program, because they've built a prison which, you know, aesthetically is very beautiful, where prisoners can cook on their own, where prisoners can, you know, they have their own keys to their cells, unheard of. So it obviously costs a lot of money, but there have been several cost-benefit analysis done from the perspective of society. And given their recidivism rates are so low, right, over a long period of time, the Norwegian system, being far more humane, costs half of what the US system costs. Even though their expenses of maintaining one prisoner are high, but because they have less number of prisoners coming back, the costs even out. And because more of the prisoners who go out get into vocations and jobs that then contribute to taxes. And as you know, Norway has very high taxation. That's the result. That's the reason why they can have these kinds of prisons. It all balances out. So in the long run, Norway has discovered that it costs less money for rehabilitation. It makes for less number of people who return to the prison, and those who come out of the prison are engaged in productive enterprises. So humanity in a Norwegian prison. If you are the Office of Management and Budget Director for the state of Norway, you will see why this makes sense. And again, it is low tech most of the time. A volleyball is as low tech as it can get, but very high touch. So Yukiko-san, if you're ready, I'm going to play another video.
Okay.
And you tell me if the sound doesn't work.
Certain things spring to mind when you think about prison.
Good.
Barbed wire, tiny jail cells, bars everywhere. Well, not in Norway. This is Halden Prison, and it's the second largest maximum security prison in Norway. And it looks more like a resort than anything else. But at 20%, Norway's recidivism rate is the lowest in Scandinavia and one of the lowest in the world. This is how Norway changed how we think about incarceration. While Norway's 2-year recidivism rate is the lowest in the world, America's is one of the highest. A 2014 study found 67% of American prisoners released in 30 states were rearrested for a crime within 3 years, and 75% were rearrested within 5 years. While it's tough to make direct comparisons, Norway is doing something right when it comes to incarceration. And it may come down to a fundamental difference in philosophy of what a prison should be. Norway banned capital punishment in 1905. 80 years later, they did away with life sentences. And in 2007, a shift in thought, a focus on restorative justice, emphasizing rehabilitation and normality over punishment. What that means is when a prisoner is sentenced in Norway, the only thing they lose is their freedom, which is symbolized by these large prison walls. Norway has two of what's been called the most humane prisons in the world. One of them is Halden Prison, where prisoners can garden, learn to cook, and tend to animals. They can also take vocational classes and prepare themselves for the outside world after they're released. Halden holds 251 of its worst criminals, which includes rapists, murderers, and pedophiles. In America, these criminals would be punished severely, kept in a small cell for most of the day with minimal time outdoors, with all of their rights stripped. The phrase, "don't do the crime if you can't do the time," applies here.
Retribution must be swift and sure for those who decide to make a career of preying on the innocent.
America's decades-long war on crime has resulted in 159,000 people currently serving life prison sentences. But in Norway, almost all prisoners are released. The maximum sentence is 21 years. At the end of this term, 5-year increments can be added indefinitely if it's assessed that the prisoner has not been rehabilitated. Even the worst offenders, like Anders Breivik, who murdered 77 people in one of the worst massacres in history, is currently serving a 21-year sentence. Norway also supports prisoners after they're released. They're provided housing, employment, healthcare, and addiction treatment. All of this does not come cheap. Halden Prison spends more than $93,000 per inmate per year, compared with just $31,000 on average per prisoners in the United States. But Norway incarcerates far fewer of their population. As of 2014, just 0.08% of Norway's population was behind bars. That's 75 per 100,000 people. In the US, it's 707 for every 100,000 people, or 0.7%. And if the United States had the same rate of incarceration as Norway, it could spend as much as Norway does per inmate and still save more than $45 billion a year. That's the budget for the entire Department of Homeland Security. No matter how many numbers are crunched on comparing recidivism rates or thoughts on punishment versus rehabilitation, it comes down to how society views its prisoners. Nelson Mandela said, "It is said that no one truly knows a nation until one has been inside its jails. A nation should not be judged by how it treats its highest citizens, but by its lowest ones." If that's the case, Norway should definitely be applauded for its humanity.
Okay. Yukiko-san, you were able to hear us?
Yes. Thank you for introducing this case. It's very surprising to me. Okay, but
Yes.
there is no question so far. So please move on to the last case.
Okay. Trying to see how to. Okay, let's see if I can go to my PowerPoint again. And can you see my share screen? Yukiko-san, can you see my share screen?
Yes.
And can you see case 4?
Yes.
Oh, I don't know why we keep going back to this. Let me just play it. I think if I play it completely, it'll probably.
Okay.
Beautiful, huh? I love these colors.
So
okay, hold on.
I deal with a question. So
oh, there is a question.
no. I can share the URL of this video.
Oh, okay, okay, yeah. Somebody says there is a small presentation arrow at the bottom you can press. Presentation arrow. Okay, no worries. I'll try to share screen again and see if this
Thank you, Jura-san.
presentation arrow. Ah, yeah, okay. Beautiful. Yes. So, Yukiko-san, can you see my case number 4?
Yes.
Okay, beautiful. So, case number 4, we title it People-Centered Governance in Tanzania. So, a few years ago, maybe, actually in 2015, I was invited by this organization called Twaweza, which is based in Dar es Salaam, Tanzania. Twaweza means we can make it happen. What Twaweza does beautifully, they do many things. One of the things they do is they work on early childhood education. And they work in 3 countries of East Africa. They work in Tanzania, Kenya, and Uganda. I know Kawamura Sensei is here on this call, and she may remember Julius, who now is a postdoc or a doctoral fellow in Japan, doing his work on positive deviance. So when I'd gone to Twaweza in 2015, that is where I had met Julius. And I was really struck by the social innovation, in the realm of citizenship, in the realm of public policy, in the realm of education that Twaweza was doing. And I'm going to talk about this wonderful initiative that they have, which I classify as being low-cost, high-touch governance. And it's called Sauti za Wananchi, which, if you translate it, means, we'll find that out. Yeah, Sauti za Wananchi means voices of the citizens. And here is what they do. It involves sampling. So basically, let's say you want to figure out what's happening in Tanzania with respect to COVID-19, okay? In Tanzania, in the country. What Sauti za Wananchi does is, using mobile telephony, they can very quickly do a nationwide survey. And the nationwide survey is done on the basis of an intact sample that they have of 2,000 people who represent the young and the old, the rich and the poor, the men and the women. Basically, this 2,000 person sample reflects their national census. And so if they need to get an idea about how things are going with respect to COVID-19, what does the population believe? Is there a paucity of masks? What are they thinking with respect to vaccination or vaccine hesitancy? They can very quickly get a pulse of the Tanzanian people, and in real time have policymakers or local officials take care of the issues at hand. So think about, mobile telephony, which doesn't cost very much, nothing. People can press their answers on, the keyboard. Press 1 if you want this, press 2 if you want this. All the data is automatically tabulated. And very quickly, you have a picture of what the nation thinks. which allows them to not wait for 2 years, oh, I'm going to do this nationwide study and I'm going to do this and then collect data and hire this and hire that. They have basically created this infrastructure at the national level. And they also work, not just in Tanzania, but as I said, in Kenya and in Uganda. And it's the use of technology, sampling, feedback, governance, policy making, all wrapped into one. So what I'm going to do is I'm going to play this videotape. And as it says, Sauti za Wananchi, which means voices of citizens, uses mobile telephony to quickly and efficiently gather survey data at very, very low cost. It turns that data into a dashboard for whatever issue that you want to address. And it informs citizens of what's going on and supports policymakers to be more responsive, as you can see, to the needs and aspirations of the citizens in real time. And when you do this, you're basically using government resources in the most productive manner, because you have feedback and feed forward built into this dynamic snapshot of what the country represents. So this video will give you a little sense of what the methodology is, and we can then maybe answer some questions. Okay. So, Yukiko-san,
Yes,
did
thank
that
you.
work out okay? Yeah.
Yeah, the video
Okay.
is very understanding and just surprising and interesting for me. So
Yeah. So basically what I was saying is we, shared 4 cases of, I want to say social innovation because they all have a social purpose. Patient satisfaction in a hospital, using low-tech, high-tech, high-touch. Karma healthcare, serving a need, as Shivam was saying, where the need is tremendous, and doing it through a model that is profitable and scalable. Over the last 6 years, there's been proof of concept. Looking at a government state-centered activity like prisons and treating people like human beings so that they can be reinstated, and overall costing less with better outcomes overall over a period of time. Then in a poor country like Tanzania, having the capability to tap into how citizens feel, what their needs are, what their aspirations are, and pretty much in real time, turning that around. But it's not just a representative sample, but it is citizenship and governance acting in ways to solve problems, which can save so much money and lead to a more efficient utilization of resources. So in summary, the message is low tech, very high touch, and also sustainable over a long period of time. So with that, thank you very much. And I am here for any questions or anything else that you'd like me to be here for.
Thank you very much. So 今から、また Q&A セッションを開きたいと思いますけれども、どなたか質問のある方は Q&A もしくはチャットに入力していただいて、話したい方はさっきのように声を出してやっていただきますし、そうじゃなくて読んでほしいっていう方はそう書いていただければ読んで質問させていただきたいと思います。So, let me ask you a question first. Okay.
Yukiko-san, I want it to be a simple question because you are, as Kunishi Sensei, known to ask very difficult questions. So please, very simple question for me.
Yeah, very simple.
Okay.
So, what do you think the definition of social innovation?
Okay. So first, let's talk about innovation. Yeah. Innovation is a new idea, a new practice, a new process, a new perspective, which finds a way to spread, diffuse, be adopted in a social system. It can be a product, it can be a process, so the notion of treating prisoners humanely is a new idea, at least in the context of Norway. Building a new prison is, a new idea in the context of Norway because the prison at Halden is built campus style. What does that mean? It means that every prisoner's window opens on the outside. If you are in a US prison, it's built more as prison style. So every case that we've talked about has many little innovations. And, the nurse assisted, for instance, the pharmacy being included, diagnostics being included. So innovation to me, in any given context, a new idea, a new practice, a new process, a new product, or a cluster of these coming together in ways that they can spread and serve a purpose. So then what is social innovation? Well, anything which has all these characteristics, but also serves a deep social need. Rehabilitating prisoners is a deep social need. Serving the underserved in rural areas, as Shivam was saying, is a deep social need. Involving citizens in citizenry, civic engagement, and participation is a deep social need in Tanzania. And for hospitals to take care of not just the patient, but the families is a social need. It's a human need. For me, when the doctor says, I'm going to carry your child to the hospital, that takes care of my needs. It's not just treating a patient and fixing it. So innovation, new idea, process, practice, product, clusters coming together, social, fulfilling, a function that goes beyond the profit motive.
Thank you very much.
That was a very difficult question.
Sorry. My next question is more simple or more difficult one.
More difficult.
Your specialty is communication. What is the important role of communication for innovation or entrepreneurship?
Okay. What is the role of communication? Innovation, Kunishi Sensei,
yes,
has no value if it does not spread. Right? If we didn't have Zoom, we will not be having this conversation. If we didn't have YouTube and the video on Holden and Twaveza and Karma, you will not know about Holden and Twaveza and Karma, right? So for any innovation to spread, the idea needs to be communicated. So I'll give you an example. In the state of North Dakota in the United States, it's got the worst prisons in the US, or up until about 5 years ago. Then the chief prison official for the state of North Dakota in the US learned about Holden, traveled to Holden, read about Holden, spoke to prisoners, came back, and now has created in the state of North Dakota a prison patterned on the principles of Holden. So that innovation and that cluster of innovation is spreading. Yeah. Karma began with 1 clinic, 30 clinics. Hyundai funded 2 clinics. This morning they said they'll fund 20, right? So the innovation is spreading through a communicative process. There's no spread without communication. Also, it's communication that reduces uncertainty, because innovations, if I didn't tell you that over a long period of time, Holden paid for itself and saved money, if you didn't have that information, it'll be like, oh, this is such an expensive system, right? 3 times the cost. So information, communication can reduce uncertainty. So the role of communication is critical in how the innovation is communicated, in how it reduces uncertainty, how people feel about it. Do they feel that it's advantageous? Do they feel that it is something that can work here? Is it compatible? Do they feel that it is complex, or is it possible? And so on. So communication is, in fact, I rarely talk about diffusion of innovations or dissemination of innovations. I talk about communication of innovations. It's because for dissemination, diffusion to happen, communication processes are quite central.
Thank you very much.
That was a difficult question.
Sorry. So, 堀さん、なんか質問ありますか？
はい。Obviously, thank you for the talking. That's so impressive for me. Question, difficult.
Easy one or difficult?
Can I ask easy one? Is there any like the sample cases or sample company or society innovative cases in Japan you interested in, or you just like or something? If you know some cases in Japan.
Yeah. Oh, do I know of?
So I want to ask you if the Japan is like a best place, better place, good place for the innovative society.
Yeah. Hori-san,
yep.
You know more about Japan than I. And Konishi Sensei knows so much more about Japan than I. And all the other people who are on this call know 10 times more or 100 times more about innovation in Japan than I. So I don't know whether, I mean, I know a little. For instance, I'm very interested and have been interested in the Deming method, the Edward Deming method for quality improvement. And we know how Japan, in the 60s and post-war II, World War II, 50s, 60s, 70s, whether it was Toyota or Sony, Japan did an absolutely phenomenal job with continuous improvement, continuous innovation, working in teams, even the processes, right? And so there is much that one can learn, I think, from Japan. I mean, we have our friend Kawamura Sensei on this call. I'm sure she can tell you about, municipalities or prefectures like Arakawa, where there are beautiful health innovations in terms of how to increase cancer screenings, how certain municipalities are taking better care of their dementia patients. As I know, there are, so I'm quite sure there are many, many good examples of it. It's difficult for me to answer your question because I really don't have a very deep answer for many of them.
All right, thank you.
Thank you. So we have two more questions. So Yamada-san, could you speak up?
Yes. Yes. Can you hear me?
Yes, Yamada-san, I'd love to see you.
It's just a comment, but so when I saw the video, so after new practice was spread it diffused it. It looks so easy, but in reality, I think there are so many difficulties to spread it out. So I think one of the reasons is the reasons for the difficulties really varied. So many kinds of the difficulties.
Yeah.
Then we think about how to solve the difficulty in a complex way, but maybe it's a long way. So I feel that if we go back to the simplicity, like you say about high tech and low touch, it's really one way to solve the situation. So we can find the answer, but it's difficult. So how we can change our mind to make it in simple and to find how to define the problem in different way. So do you have any comments?
You know far more than me, Yamada-san, than I do, but I do think there is value. I mean, clearly, if you look at karma, it sounds very easy, but can you imagine building that technology platform, using artificial intelligence for triage? You can only do those things after a lot of hard work. a lot of working out details, even connections, how do you connect rural areas? So, they have mobile backups and so on and so forth. How do you have the equipment so that as soon as the blood pressure is checked, it goes directly to the doctor, and so on and so forth. So I do think, though, even though I don't, far more than me, that if there was a simple message from all the 4 cases, it is the importance of high touch. And, whether it was low tech or high tech, I mean, karma sounds low tech, but, of course, but all of them. So for instance, in the karma model, the value of the nurse who welcomes you, who is, who welcomes you, who gives you a glass of water, who, is kind to you, who introduces you to the doctor. The doctor introduces himself or herself to the patient. Yeah. They fill out a survey, as they leave, my satisfaction score, and so on and so forth. So what I think distinguishes, or the simple message, is focusing on the high touch, because that is humanly possible. Human beings are at the center, whether it's prisons, you can decide to sit in your guard room with your gun and with your this, or you can be out playing volleyball. And, it's high touch to be out there playing volleyball. And of course, the prisoners know that the guards don't have a weapon, and they also know that if they breach that contract, if they are not respectful in return, they lose their privileges, right? And so on. So whether it is Tanzania, Citizens' Voices, or whether it is Norwegian prisons, whether it is karma, or of course, the doctors who took care, I would say that the simple message is high touch.
Yeah, thank you. I think it's really reasonable answer. So maybe it looks easy because the technology is common. It's common. So everywhere we have the same technology, maybe better than India or Tanzania. Yeah. But most of the case, we cannot apply the technology because of we lose their high touch part. So I understand. Thank you for your answer. Thank you.
Okay, next question from my student, 渡辺さん。今、パネリストにしたので、顔も見せていただいて、はい。可能かな？いますね。はい。
Hello.
Hi.
How are you, Watanabe-san? Yeah, is it a difficult question for me or a simple one?
I don't think so. That's a very easy question. So in my opinion, all innovation has some social impact. Then why do we call some innovation, social innovation? So why do we add social to some innovations?
Okay. Yeah.
That's not the difficult question.
That's good. So Watanabe-san, can I have a dialogue with you? What would you like to call them?
Well, I just call them innovation, not the social innovation. Yeah. So why do we call them social innovation? Well, yeah, I can understand.
Yeah.
Yeah, but I just wonder why.
Yeah. No, I think it's a very good question. So there's no reason why we just can't call them innovations. That's the reason when Kunishi Sensei asked me my definition of social innovation, I said, first, let me define an innovation. And then let me add social. So if you choose to just call them innovations, that's fine. I think the distinction that we were making is there are some innovations, a lot of them, which don't have socially desirable effects. Okay, so you may, and I have nothing against people who sell Coca-Cola. I actually have some friends who sell Coca-Cola, but I will not call Coca-Cola, the enterprise of Coca-Cola, a social innovation. Well, it's social in the sense, yes, it provides jobs, yes, but what it does, it basically rots teeth, and it leads to obesity and all kinds of problems. Compare that, let's say we compare that with an enterprise that provides eggs to and promotes poultry farming among those who are living in rural areas, and gives them a way to create more nutritious meals through eggs, which are very nutritious. No? So you may say you're still selling, and whether it's Coca-Cola or poultry farming, there may be innovations in that context. But what we are saying is the attention to the social dimensions are woven in a little more purposely. One can use karma. I mean, I have asked this question, why don't you use karma in cities? You can use this model in cities too, right? And he said, that's not the purpose. The purpose of karma is to provide services to those who are in rural areas, and so on and so forth. So your point is excellent, but we add the word social because even though there are social impacts of everything, here the intentionality, I mean, a Buddhist philosopher will tell you that the world arises from the tip of intention. And so if the intentionality is to connect citizens, if the intentionality is to not just fix a patient but to heal the family, if the intentionality is to treat somebody who's done an offense in a humane manner, there is deep intention behind it, and it is to recognize that intention. No, so, but I'm okay if you just want to call them innovations with social impact. I'm okay with it.
Thank you very much.
Thank you for that.
Okay. So next, so Kawamura Sensei. So
Kawamura Sensei.
I'm sorry again. Me again.
It's so good to see you.
Good to see you. I'd like to add some Japanese context, which
Please.
I'm thinking, because we are very good at being kind of creating the system of being human-centered, which is like a high touch. But once we systematize, the practices, it cannot be truly high touch. So yesterday I was talking about I was talking with the students from Bangladesh, and he said that how convenient Japanese society is, and he was talking about that friends are living in U.S. and then they used to live in Japan, and then they're kind of complaining about how inconvenient the life in the U.S. are. So I felt like we are very good at making the system, and so that sometimes we can get away from being humane. I felt like as I was listening, the discussion with you, you and Mr. Holly, and so I felt something like that. So it's my thought.
Yeah.
Thank you.
No, well, thank you for that. I mean, if you go back, Kawamura Sensei, to the whole writing of Marx, Karl Marx, who was absolutely brilliant philosopher. And I think Marx was deeply misinterpreted by, the Lenins and others, but that's another debate. But that's basically what he was saying, that when you have routinized processes, then there is a sense of alienation, right? That comes in. And you become a sort of a cog in the wheel when the processes are routinized. And when you become a cog in the wheel, it is easy to lose your humanity. And I think what Yamada-san's question was, what we are saying is the notion of humanity, even with becoming a cog in the wheel or a gear in a car, has human agency, has choice. And we are not saying that that choice needs to be exercised every time by everybody, but even that can be looked upon as an innovation, like the humane movement, right? A movement to respect the planet, right? A movement to respect the other. Unfortunately, we have to do things in routinized ways, and that does rob us. That makes it difficult for us to be conscious of, the human beings that we can be.
Yeah, thank you so much, because we love manuals, right? And we are very good at following manuals. But I remember my friends like Ito-san and probably some other consultants said that while we are learning positive deviance, we hate it. We started hating manuals like that. So anyway, thank you so much.
Yukiko-san, this may look like sake, but it is not. It's coconut water from the Philippines.
Okay. Very healthy. So the last question from my student, Joya-san.
Joya-san. And Joya-san, let's see you if you don't mind owning your video. It's always good.
Okay, it's working. 1 minute, please. My video is actually not working, so if you don't mind.
No hurry. We are in no hurry. We have all the time in this.
Okay.
And if you need to comb your hair, feel free to do so.
Is it working?
Very nice. It's working. And
thank you. So basically,
Joyan-san, we can't hear you. You may need to unmute yourself. Although I can be I can read lips.
okay, it's working. So I wanted to ask, do you have, Professor, do you have any social media platforms so we can get updated more about you? Facebook, LinkedIn, anything?
Everything.
You have everything, okay.
Everything, Joya-san. You can find me on LinkedIn. You can find me on Facebook. I'm very happy to say that even Konishi Sensei and Kawamura Sensei thought that it was okay to be my friends on Facebook. So I'm available everywhere, and if you think there is some value in connecting with me, please do so. And this is not just to you. I think you are asking on behalf of others. I'm available.
Okay, thank you so much, Doctor. Honestly, I've learned so much from you, like especially since I'm like a biology department student and aspiring to move more into healthcare.
Fantastic. And are you Japan-based at this time, Joya, with the beautiful name that you have, Al-Khatib? I actually have a friend whose last name is Al-Khatib.
Yeah, it's a pretty big family. Is he Arab like me?
It's actually a she.
Oh yeah.
So it's Maisa Al-Khatib.
Yeah, we like it's a really big family. So I think if I knew the area she's from, I would know her, but for
Yeah.
now.
Yeah.
So yeah, I've learned many things, especially from your personal experience that you explained at the very front of the presentation. I never knew like how important the neonatology department is. So like I'm familiar with many other medicine branches like neurology and gastroenterology, but I've never knew how important like that department is and how significant it could like affect patients and so on.
Quite true, Joya. And I didn't know much about it until we had a preemie baby. You know, our first son was healthy, you know, we never thought. And then, of course, so yeah, you know, life has its own ways of connecting us with certain things, as life has its own ways of you and I connecting over this platform.
Thank you. So the last question from my Japanese student, Tashiro-san.
Okay, Tashiro-san.
I don't know if it gets the point, but my question is, in order to create social innovation, is it good to focus on medical field? Because I thought this field can be operated by governments rather than economic entities. So I thought it's difficult for us to create social innovation within this field, because governments will intervene. That's my question.
Okay, thank you. It's a very good question. So oftentimes when we think, Tashiro-san, of social areas, you know, you have education, you have health, you have governance, you have citizenship, you have, you know, public service, public good. So yes, you know, these are the kinds of areas, but in general, we are looking at well-being, no? Well-being of citizens, well-being of families, well-being of prisoners, well-being of students, no? Well-being of patients. And so the innovation really can come from anywhere. It can come from the government, it can come from the private sector, it can come from public-private partnerships. So for instance, in Twaveza, they have a mobile phone company that's a partner. They have citizens who are partners. There's a non-governmental organization, Twaveza, which is a partner. And then they produce reports which go to citizens and policymakers. No? So oftentimes it's useful to think of an ecology of interests, an ecology of institutions. And within this ecology, you know, you can see where there may be process or technological or a practice or a service innovation. Yeah, but thank you for that question.
Thank you.
Thank you very much. Unfortunately, it's a time to finish. So thank you very much, Arvind-san, for the informative speech. So I found the subject is relative and very interesting for our student and the audience as well. Thank you very much.
Thank you, Yukiko. san and Hori-san, and for all my friends who've joined this call. And you did ask me very difficult questions, but I still love you, and I hope we will continue to connect. And feel free, Yukiko-san, to share my email address with everybody.
Okay.
Yeah.
Thank you very much.
Thank you. Bye.
はい。では視聴者の皆さんも最後までどうもありがとうございました。14時から第2部もありますので、ぜひご視聴ください。ではありがとうございました。じゃあ消しますよ。いいですかね。消します。
はい、閉めましょう。じゃあ、お願いします。